moving swiftly on to our next presentation, it's a pleasure to introduce two excellent speakers who are moving on to look at the upper airway and the visualization of the upper airway. And I think they're going to give their talk together. So Tina Anderson and Michel Toussaint, if you'd just like to join us, and we're very much looking forward to this.
How is it possible? How is it possible that I was invited in this meeting to discuss that topic? Incredible. Can you believe that I made 800 kilometers to discuss the need for upper airway visualization to assess MIE treatments? Can you believe that?
Oh, I'm so happy that you traveled 800 kilometers, Michel. I have learned so much from you during all the days. Maybe you learned something from me today.
We will see. Do you know what, Dr. Tina? I have worked for 30 years without looking at the upper airways. 30 years. Do you mean that I am a bad clinician if I do not look at the upper airways? Is that what you mean? Please. Are you criticizing the audience here if they do not look at the upper airways? Is that what you mean?
Yes.
Come on, come on. Do you know what? We should perhaps decide to stop this discussion here. Let's stop perhaps. Because you cannot argue that upper airway visualization is useful. First of all, I'm quite sure that there are no studies to support any evidence on that.
Oh, poor Michel. Haven't you opened your computer during the last 20 years? Already in 2004, Jesus Sancho from Valencia in Spain opened up to look up and visualize the upper airways. And he used CT scan and saw that there is a constriction during exsufflation in ALS patients. This is a little bit more difficult way to do it because you have to time when to take the picture. So they only took pictures from baseline and exsufflation. In 2013, we introduced a method that was feasible to visualize upper airways during dynamic MIE use. And we used this technique, transnasal fiber optic laryngoscopy. And we saw clearly what was problem with these bulbar ALS patients. The insufflation pressures, the positive pressures, caused a closure in the larynx, and it was predominantly at the supraglottic level, above vocal folds. We saw that it happens either at once or during the insufflation we provided, and it was completely different from the healthy persons and spinal onset patients. And that was really important because we realized that we have used MIE device completely wrong with ALS patients. So we need to give less pressure in insufflation. We need to use longer time to increase this insufflation pressure, and we need to use longer time to achieve this expansion and volumes as was described.
Okay, interesting. But this happens only in bulbar patients, right? Okay, now it's documented, right? And I wonder that there is no need for further investigation.
Dear Michel, we also investigated patients with no bulbar symptoms, and we followed up a cohort of spinal onset ALS patients up to 5 years in their disease progression. And we see that this happens also in those patients before they get any other bulbar symptoms, and it always happens first with the high treatment pressures. And can you believe we also examined healthy persons in comparisons? We have a slight technical problem in my argumentation. Maybe you have done something with this computer, Michel?
No, I swear, no.
Okay, it's not changing. Anyway, we also see that there is adverse events in larynx in healthy persons. The positive pressures will blow the epiglottis as a retroflex movement, and we also see that also healthy persons get that hypopharyngeal constriction during exsufflation, as Sancho showed a few years ago. Maybe technicians can start over the presentation.
So I start again. How is it possible? Can you imagine? Oh, sorry. Okay. So finally, upper airway visualization during MIE is only useful to conduct studies. I wonder. Come on, there is no need to do it in the clinics. In the clinics, I mean. Okay, studies, clinics. Do you see the difference? Have you seen patients finding it useful for themselves?
Oh, Michelle, you need to see this patient. She is a patient with ALS. She started treatment during her illness. It was really challenging. During pneumonia, we individualized the settings every day during the hospitalization, and she was in our unit 30 days. She traveled home with new settings, managed to use the device 1 year, and then it stopped. She started to retching during MIE. And then we visualized the upper airways, and we tried to find what is more beneficial. And see, this is the latest video from her from this summer, and she still managed to use the device. Here's another patient. But there is many patients we do that. We do that on the bedside. We have transportable laryngoscopes. We titrate the settings when they are even ill. I had also a picture from a young patient with the SMI type 1. I think they are doing that.
They are busy.
And she had still lots of secretions, pneumonias, hospitalizations, and then we just looked to the upper airways and we saw that the same thing happened with that SMA1 children as it happens with ALS patients. So by titrating the settings with the upper airway visualization, we managed to help further.
Meantime, knowing how diplomatic I always am, I'm sure that both Michelle and Tina are right. As you know, I'm very diplomatic all the time, but there is always something more to the story. Now, I'll tell you what that is right off the bat. It's not simply spinal or bulbar or SMA1 or ALS. It's upper versus lower motor neuron disease. Now, Tina, SMA1 is lower motor neuron disease, and we have lower expiratory flows on an exsufflator in children and babies, and that's why they get lots of pneumonias. But after they're 3 or 4 years old, that doesn't happen anymore, and maybe it's because they're able to cooperate with the machine. But certainly for the adult patient, it's a question of upper versus lower, and that can be upper spinal or higher.
Are we
Okay for you?
Yeah,
Success.
it's okay. Thank you, John. I don't think it's that black-white with upper and lower, as you say. Because with the lower motor neuron disease patients, we see that the insufflations is a big problem. But that's another debate.
The bottom line is, what is the flow? What is the inexsufflator expiratory flow?
Yes.
See, that's really the bottom line. I think Michelle would probably agree with that.
Yeah, maybe. Have you think about the saliva retention in the larynx? Do your patients have any saliva problems in their larynx? And when you apply the positive pressures, we might blow the saliva to the lungs. And here's one case report from UK who showed that the saliva retention combination with MIE use could cause aspiration pneumonias. And this is what we see when we visualize the upper airways, that we are blowing the saliva down to the lungs. So we need to know what we are doing.
Yeah, do you need that? Oh, no problem. We know what we are doing without all of this, personally. In addition, Dr. Tina, there are several economic aspects here. This requires, I wonder, expecting expensive equipment and very specialized skills. Only very specialized clinics can do that, right?
Yes. Now we are in the point in our discussion when I agree to stop this discussion, because these equipments already are in the hospitals, in several departments. And of course, we need some help to start with these examinations. And we get help from our technicians. We use the masks, we use the scopes we have. They had silicone plugs we could adjust to be adjusted to the scope, so we get sealed masks during the examination. And it's not that difficult.
No, really?
No.
Well, Dr. Tina, would you or your colleagues accept to undergo such examinations? Isn't it very painful to get that endoscope through the nose? Did you try this?
Oh, Michel, I have tried that more than 30 times.
Really?
Yes.
Impressive.
And so we anesthetize the nose slightly, and skilled hands used scope. It takes maybe a minute to place it to your nose, and then we have a good view. And then we can start to use these therapeutic pressures to look what happens. And this is one way to do it. There is also increasing interest to use diagnostic ultrasound with this. And we have an ultrasound expert here talking afterwards, George Pneumotopoulos from Australia. We together, we will start next week a new study comparing ultrasound of the larynx and visualization of larynx with the laryngoscope. That would be interesting. Don't you agree?
Yeah, not a crazy visualization, I wonder, probably. And what about the skills, Dr. Tina? Is it possible for us as physiotherapists to interpret laryngeal images? It looks like complex, no?
Oh, Michel, no, you stop, Dr. Tina, Dr. Michel. Well, you are right. We need to learn some anatomy, and we can some anatomy from before. Of course, we will interpret the results as a physiotherapist, not as a doctor who are searching for pathology or cancer. And if we are unsure, we have these video recordings. We can always show them to more specialists and get their opinion. And we physios, we are also masters to describe and analyze the movements. So I will say we are maybe better to analyze the movements in larynx than otolaryngologists.
Okay. There might be some indications to do that, okay? And it looks that it should be feasible, but I think it will be important to discuss when to visualize, for which patients, I think, and in which environment. What do you think about it, Dr. Andersen?
Oh, Michel, I would do anything to make you happy again. So let's do it.
Yeah. Probably we have to give a conclusion for the audience. Do you agree?
Yes.
So perhaps the first question should be, can the patient use MIE? No, two possibilities here, or yes or no. If yes, I wonder there is no upper airway visualization required.
I agree.
Okay. But if the patient cannot use MIE, tell me if I'm wrong. If the answer is no, then the question is, do you think that this might be related to the upper airways? Again, two possibilities for a response. No upper airway visualization required, or possibly yes. Okay, do you agree with that?
Yes.
Okay.
And in that case,
Yeah.
if you think it's related to upper airways, maybe you can start like Paddy was suggesting, that we try to individualize and adjust the settings first. And then if it's, how about if it's not sure?
Yeah. A third possibility is if we are unsure. So perhaps the last question should be, can the patient do air stacking? So in case of yes, I wonder, no need for upper airway visualization.
But if it's not, maybe we should visualize the upper airways.
Okay.
Are you a little bit happy now?
Yes, I'm slightly more happy, more than the technology today. Thank you very much for your attention.
Tina, Michelle, thank you very much for an excellent talk. Sorry for the technical issues. I think it would be interesting. We'll open it up to the floor to some questions. I think that, George, you had the first question, then over on the left.
Paddy, thank you. I've got a question for both of you because I can see both sides. But Tina, I'm worried that putting the scope down and anaesthetising the area, how much of the problem are you actually causing? Are you causing some of this dysfunction by instrumenting the patient and by adding drugs down there?
Yeah, so we anesthetize the nose and maybe a little bit of the oropharynx, but we stop the scope behind the tongue, so it's not in the larynx, and we are not anesthetizing the larynx because we are not there with the scope.
But how much do you think the scope itself affects? For example, what's happening in terms of laryngeal responses?
Of course, we need to, and we see it if we are touching the mucosa, it might cause some adverse events, but it still gives so much information that we choose to do it.
But somehow I therefore think about Michelle, and I think maybe we could maybe not need it sometimes.
Not maybe.
Thanks very much for the question over on the left.
Congratulations, Michelle and Tina. I have some questions. Nowadays, it's very important, the effect of upper airway in management of respiratory secretions. And as John says, I think that the main problem is the upper motor neuron. Okay, I think some issues about the use of laryngoscopy. In your paper, you cannot visualize the lower structures in all the patients. So this is a problem that there are events that we can see. And what do you think about the effect of the presence of a laryngoscopy into the upper airway and the effects on the flow generated or the effects of the upper airway reflexes?
Yes. So the scope is in the nose. It's not lower than above the tongue, base of the tongue. So I believe that when we use MIE device, we often instruct the patients keep their mouth open. So the most of the flow is going through the mouth, not through the nose. So it will, of course, may cause some obstruction, but do we think if the patient is obstructed in their nose when we are using MIE?
But some flows are going through the nose.
Yes, always.
And go into the lungs through the nose.
Yeah. Yes, but still, I don't think it's the main problem with that. But of course, we need more evidence, and we also need to combine both the visualization and the flow curves. I will have another session afterwards, monitoring, and I will. And I know that Jesus, you have also done big work there, and we are looking forward more from you. Maybe you have answers.
There's always more questions than answers, I think, Tina. I think the visualization of the upper airway from a research point of view has been hugely informative, hasn't it? And the realization that it's an important part. I suppose my only question is, and you just alluded to it just then, is whether using flow volume loops and curves can give us the same information but without having to put the scope in.
Yes, but I think it's important to do those both because we can create a language what those obstructions on the flow curves means.
Yeah.
Also.
No, I think I agree. That'd be really informative. I look forward to that work. But thank you both very much. A really great talk. Thank you.